Good evening, everybody, and welcome to Prostate Forum here in Southern California in the United States. I'm Neil Burke. I am the CEO of Prostate Forum, and we have a treat tonight with the return of Dr. Ali Afshar, who is a surgeon at both Cedars-Sinai Medical Center in West Hollywood and at Providence St. John's Hospital, which you might have known from the past as the John Wayne Cancer Center in Santa Monica. He is joining us again, and he's bringing with him some new technology, which is Focal One, robotic, focal, high-intensity ultrasound therapy for ablation of prostate cancer. Now, previously, he has been with us for other forms of focal therapy, and we're looking forward tonight to talk about Focal One as a means of making precision cancer treatment even more precise. With that, I'd like to turn this over to Dr. Afshar.
Hello, guys. How are you doing? It's a pleasure, and thank you for having me on this meeting. Of course, prostate cancer is a very important topic for most of us males, and also we tend to deal with prostate quite a bit. Everything in our body gets smaller, prostate gets bigger, you have urinary problems, may cause prostate cancer as one of the leading causes of death in males. Now, what do we do when we encounter this? BPH is a different talk, but prostate cancer obviously is very important and can impact our life very negatively for certain treatments. How do we treat it? What do we do? A lot of anxiety associated with it. Disclosures, I wanted to mention that these are the companies I consult for, EDAP, AngioDynamics, and Profound Medical. The agenda today is to discuss the PSA, treatment options, and also what we are going to do, and then talk about the focal therapy, specifically thermal treatment, which is HIFU. And we're going to talk about who's suitable for this treatment, what happens on the day of the treatment, what happens afterwards, and some clinical data. I picked out a patient to mention to you guys, and then we can have some questions at the end of the talk. Elaborate before you go to your primary care physician. They get your PSA and they say, oh, your PSA is elevated or your PSA is normal. What does that mean? Some of the information you should have for yourself. Maybe the clinician would not be looking at it as a whole picture. Always understand that you're the person who's driving the bus, not the primary care physician or any other person. You are the owner of your own information. PSA is a protein that is produced by tissue. This value was found in 80s. They thought this is the holy grail for prostate cancer. And everybody that they were high, they all got prostate biopsy, and quite a bit of people, unfortunately, lost their prostate unnecessarily for types of cancer that would have not done anything to their life expectancy or changed their life or caused the mortality. That's why PSA alone is not a good measure to diagnose somebody necessarily with prostate cancer. A lot of other things go to it, which I will mention it just briefly. Right now, you go to your doctor and they say your PSA is elevated. So they took the value of 4 to have the test sensitive as well as specific. That means if they would have taken the PSA of 2 and higher, a lot more people would be screened and less likely to find cancer. And higher than 4, if it was 6, hypothetically, we would have missed some very important cancers and less likely to have the patient to under workup. So 4 was the in an area which they found to be a good number as a cutoff for workup. However, gotta understand that not every person with prostate cancer has a high PSA, and not every person with a high PSA has prostate cancer. That means that, let's say, hypothetically, your PSA 3 years ago was very low. It was 0.5. The following year was 1.5, and the following year was 3.8. That makes me wonder if there is cancer, because we look at the velocity of how fast it is rising. While a patient, first time you get the PSA, their PSA is 6. You work them up for cancer. Some people, they go on their workup. Or you see a person that just shows up for a workup after a few years and look at their past, and their PSA over past 3-4 years has been between 5.5 to 6.5. That means that person does not have cancer, and if they have prostate cancer, probably is low risk. Anytime you see a physician, you want to go under workup, you want to find this, you should try to get your previous values, not just show up with that value that you have for that day. That's going to help to drive the workup for the patient. But a lot of different tests, different conditions also can impact the rise in PSA. As I mentioned, not all are cancer. It could be because of trauma. It could be infection. It could be familially elevated PSA. So PSA is not a diagnosis of cancer. It's just a tool for us to try to screen. Now, you show up to my office, for example, and you have an elevated PSA. I get your PSA again to confirm it's elevated, but also I get the free PSA is the PSA that is not bound to any protein, and that is great value to know, especially between PSA of 4 to 10. The lower the free PSA, the higher probability of cancer. If your free PSA is greater than 25%, let's say 33%, 35%, then my suspicion of cancer is lower. When we see a patient originally and we see the PSA, I ask certain questions. We do a physical exam. I find out if your prostate has an abnormal nodule, if you have family history of prostate cancer, what your PSA is, what the free PSA is, what your race is. Then I put it in this calculator. And then that gives me the probability of, if I take you to biopsy and I get 12 cores, what are we expecting to find? So that's one of the tools that we use. Based on the PSA, your family history, your symptoms, I tend to, if I'm suspicious, I tend to get a prostate MRI. Prostate MRI is a great tool, but that's not still a diagnostic tool for saying that somebody has cancer. It could have an area that is highly suspicious for cancer, but that's not still a diagnosis for prostate cancer. It could be sometimes the MRI can pick up infection that looks like possible index lesion that could be cancer. So have to take that into account, have to read the MRI, and there's certain values that we look at MRI. I mean, all of these things are probably a little bit too much for the meeting, but we look at something called the apparent diffusion coefficient, which the lower the number, the higher probability of cancer to be higher grade. MRI is just not saying that there's a lesion there, but we need a lot more information. I also tend to, when I'm suspicious for that, I also get urine tests, certain urine tests in the office that they're validated to give us a probability of presence of cancer and what's the percentage of you having higher risk cancer. So I tend to use ExoDx. There was a study that came out of UCSF. When they combined the two, they were able to forego about 42% of unnecessary prostate biopsies. So I tend to do that for my patients. After all of this, the next step is to obtain a prostate biopsy. If the MRI of the prostate shows an area suspicious and the urine test places the patient as a higher probability of having higher risk prostate cancer, then I tend to do MRI fusion transperineal biopsy. I rarely do transrectal anymore. I do transperineal because I'm comfortable with the procedure, lower likelihood of a patient getting infection. And also I am able to target the anterior aspect of the prostate, which is very difficult with the transrectal biopsy. When you combine the MRI with the truss and you obtain a biopsy, we found that you have up to or greater than 90% chance of finding higher risk prostate cancer, comparable to random biopsy, which you do with the transrectal biopsy, or cognitive MRI, which, I mean, you're like, oh, I think the MRI shows the lesion over here, so I'm going to use the transrectal ultrasound and I'm going to take a biopsy course from there. I do a transperineal biopsy under sedation, which allows me to do more cores and obtain more areas of the prostate than a regular transrectal ultrasound guided biopsy of the prostate. Now, after this, we find prostate cancer. Prostate cancer has their difference. Let's say 10 years ago, prostate cancer, the way that we broke it down was low-risk prostate cancer, meaning Gleason 3+3. Gleason was a physician who looked at the cells under the microscope and categorized them from 1 through 5. We don't look at 1 and 2, and they're not even mentioned in the pathology report. However, Gleason 3, Gleason 4, and 5, and a combination of 2 of them, the most common pattern that you see and the second most common pattern that you see. So you combine both of them. If you hear Gleason of 6, 7, 8, 9, 10, basically that could be a combination of different things, 3 plus 5, 3 plus 4, 3 plus 3. So that's a combination. For low-risk prostate cancer, it is named as 3+3, Gleason 6, PSA less than 10, no nodules, no extracapsular extension. So that would be referred as low risk. Then the intermediate risk, there are 2 groups associated with it. It could be 3+4, which is favorable intermediate risk, and 4+3, which is unfavorable intermediate risk. And that's because Gleason 4 is more likely to advance and metastasize comparable to Gleason 3. Now that can be also influenced by prostate nodule or a PSA greater than 10 up to 20. Next category is high-risk prostate cancer. That's any prostate cancer that is Gleason 8, meaning 4+4 and higher, or PSA of greater than 20. So that's the way that we used to talk about it 10 years ago. Nowadays, we break it down into 5 groups. Grade group 1 up to 5. 1 being the least aggressive, Gleason 3+3. Group 2 is Gleason 3+4. Group 3, Gleason 4+3. Group 4 is 4+4. And group 5 is the highest risk, which contains grade group 5, Gleason 5 prostate cancer. Up to recently, still actually the NCCN guideline in the United States, they consider the prostate cancer treatment for the patients that required as a couple of different treatments, which includes active surveillance for low risk, or undergoing removal of the entire prostate. Now we do this robotically. It could be multi-ports like the picture, or a single port, which is a single incision, or undergoing radiation therapy, which there are multiple different kinds of radiation therapy, including brachytherapy. These are the mainstay of treatment. We've been doing this for decades. We have robust data that these are great treatments. However, these treatments have side effects, and not every male wants to deal with the side effects. One can say, okay, I got my cancer out, but I don't feel like a man because I cannot get any more erections. I leak urine. I have to wear diapers. And this is just not something that fits me. And there are different types, and maybe they don't want to have such an aggressive process. So there is another therapy that came along, which is the focal therapy, meaning that we treat that area of the prostate while leaving the prostate in place. It's a same-day therapy. We'll get into it more, but there was a 7-year follow-up. They looked at multiple different follow-ups for treatment of prostate cancer. Active surveillance, meaning that we are actively looking at you. Every 3 months after you choose for it, we get the PSA, you get a rectal exam. At year 1, you get an MRI of the prostate, followed by prostate biopsy. If nothing's changed, then we continue to follow you with the active surveillance. 37% of patients after year 1 active surveillance will change stage and they will require some sort of a therapy. As you can see, active surveillance is preferred because it's less likely to impact your lifestyle unless it advances. Radical prostatectomy and radiation therapy, which I mentioned, has been done for years. A lot of data available. They have probability of developing erectile dysfunction up to 60 to 70% of the patients. For radical prostatectomy, most likely at the beginning after the operation, you will be incontinent. Most patients regain it these days. However, it just depends on how the surgery was done and how strong your pelvic muscle is. But other things that can happen, you will lose the ability to ejaculate almost universally with both. Over here says greater than 70%. I have not met a person who has had radiation therapy that says my ejaculation is intact, but I guess some out there at this institution that did the study. In prostatectomy, you lose it, and erectile dysfunction rate is high. However, it is a great procedure, low likelihood of cancer recurrence. And that's not acceptable by every male. Not every male looks into say, okay, I have cancer, I have to get rid of it, but I'm going to be miserable for the rest of my life because all of these things, all they're very important to me. I just want the cancer out. Not everybody's like that. Now, where did the focal therapy came along? At first, when they started doing thermal therapy with HIFU, which was the main modality for the treatment, they started with the low-risk prostate cancer. They did the trial. They saw that it was effective. However, we have learned that low-risk prostate cancer, low volume, doesn't really need any treatment. It's like having diabetes, but you follow up. And if you develop any advance of cancer or not, which is low probability, unlikely to be the cause of your demise. Now, intermediate group, which could be Gleason 3+4 and higher, there is a subset of patients in the Gleason 3+4 intermediate disease or favorable prostate cancer, intermediate, favorable, intermediate, we can do active surveillance. But the rest, depending on the results, depending on how many cores are positive, depending on how your prostate looks like, or you went from a Gleason 3+3 on the following biopsy, you went higher to Gleason 3+4, then we recommend some sort of a treatment. And the other category would be high risk. Certainly for high risk, you want to be more aggressive, which would be surgical removal of the prostate, radiation therapy, androgen deprivation therapy, plus radiation therapy. There are many ways to go about it. However, that's the one that we worry the most. You want to get the most aggressive treatment to try to control the disease. In between, there are many treatments. Those two treatments for some patients in the intermediate risk are too aggressive, meaning that their amount of cancer is not as extensive. It's maybe one side of the prostate. They just got married. They want to live a normal life and they have low risk. So those people, they have an option. They have an option called focal therapy, such as HIFU, which is a thermal therapy. You have cryotherapy, you have nanoknife, which is non-thermal, many of those options, but you have to see which one is safe and effective for those patients to avoid any failed therapy. Now, other patients who has had therapy in the past, such as radiation therapy, now that they have recurrence, HIFU gives a chance to be able to treat that site that occurred in the prostate. So that's positive. That's a wonderful device to have for this subset of patients. HIFU over here, which Focal One, the device that you see is the Focal One device. I will talk about it a little bit more in a few. So you are able to treat low risk, intermediate risk, and maybe some patients that they're not a candidate for surgical treatment with radiation or removing the prostate. For example, I had a patient who had a high-risk disease. He has had radiation to his pelvis and abdomen. He has had surgery in the past, which they did a J pouch, removing the rectum. So he's not amenable to surgery. He's not amenable to radiation. And unfortunately, when you use the J pouch, you use staples, which you cannot do HIFU. So I was able to treat him with nanoknife safely, and he has been cancer-free for 3 years in that spot. So you have those certain patients that this can be a great option. Focal therapy. But however, we look at patients that they have low potential for more, they want to have low impact on their erectile function. They want to have low impact on their life or incontinence. They don't want to go through extensive therapy with surgery, and they don't want to get radiation, which can be a couple of weeks of treatment with different types of side effects. Also, secondary cancers. Radiation can cause secondary cancers. We're learning about this more and more. Now they're talking about how CT can cause more cancers. More than the past, some studies came out, and even MRI is being mentioned for it. So radiation can cause a lot of issues for us as well. You can treat the recurrence cancer. However, if you have high potential for morbidity, obviously radiation therapy and surgery is the best way to go about it, especially with life expectancy and risk, survival risk, and metastatic disease. Now, what is high intensity focused ultrasound? The way that it works is that I call this a spyglass, but it's a magnification glass. If you ever held that when you were a kid over a bug or a leaf, you could concentrate it when you burn that bug, insect, or the leaf. So this is a similar idea. The probe of the ultrasound produces this high frequency and focus in one area that causes the thermal ablation of that area. And what we look into the thermal ablation for the prostate cancer to be able to heat it at least up to 55 degrees of Celsius. And there are some limitations. The reason for the transrectal approach, there are certain limitations, but that's the most common use. We have the most data available, and we know it's very effective. So again, one procedure doesn't fit all. Your physician who talks to you can determine what's the best approach for you, but you also should be able to should know what are the options out there so you can discuss with your physician. If you show up to a regular urologist that does only surgery, the chances of for that person to talk to you about the presence of focal therapy such as HIFU is very minimal, and most likely going to recommend you to avoid it because number one, he does not have any experience with it. Number two, we urologists, we go to all these years of schools and years of surgery training to learn how to remove the prostate. So naturally, some of these urologists, not that they're bad, they're great. Some of them are absolutely amazing urologists, but they don't trust other technologists other than the way that they know and they trust. Gotta understand that there's focal therapy out there, but this is so unique that you can precisely get up to and to treat the area that you want in the prostate specifically. This is the machine composed of multiple areas. Let me see if I can break it down for you. As this area is the probe, which is the transrectal probe. Over it, we put something like a condom, which is filled with this cooling gel or fluid, because when you're treating transrectally, you don't want to heat up the rectum. So that's very important for us. However, the technology allows us, even though we push the prostate further away, we are able to concentrate on the area of the prostate we want to treat by frequency. This is the working station, and over here it has a very high quality ultrasound, which we are able to fuse it with your MRI, basically create a 3D image of the area of the prostate, the area that is suspicious for cancer, including the areas which you biopsied and you found cancer. So it has that technology and capability, and in live picture, we can see what area we are treating. Advantages: there's no incision, which is huge. There are no blades, no scars, and you don't get radiation therapy, which could have quite a bit of negative impact in different ways. And also, one thing to remember, with HIFU, with focal therapy, you're not burning any bridges. It works, we follow, we have a certain threshold that we look at that I will talk about it later on. However, if the cancer returns, you could redo focal therapy, you can remove the prostate, you can undergo radiation therapy. So to me, it's a win for us males to try to maintain our life with the diagnosis of prostate cancer, which is devastating, can be devastating, especially with knowing the treatments and everything else that you have to go through. The quality of life, you get back to work as soon as the catheter out, or some people with the Foley catheter can resume their work. I've had patients that they went to work 2 days later with the catheter, not a problem. You get back to life. With surgery, you have at least 2 weeks of downtime after laparoscopic surgery to get back to your normal self. 4 weeks, you cannot lift any heavy weights because of the possible events that can happen, such as hernia. It's a same-day procedure. You go home. Also, it carries lower risk for incontinence, lower risk for erectile dysfunction. I think the cumulative for it is about 21% across. And also that depends on what modality that you use and where are you ablating. You can stay away from the nerves and decrease the probability of erectile dysfunction. Now, who is suitable for treatment of prostate cancer? As I talked to you earlier on, the active surveillance, which are low-risk prostate cancer, active surveillance is probably the best choice because any treatment may have side effect, even focal therapy for a cancer that is not going to be the cause of your demise. And as long as you're following up with your urologist or oncologist, you are under control. And if something changes, we can attempt to treat it. However, it's unlikely for it to advance where it causes metastasis to bones or impact your life expectancy. The next category of the people are the intermediate people, which is the bridge from some patients that they have low risk. They're unable to there are some patients that they just can't stand the idea that there's cancer in their body, prostate cancer, even though they're low risk. So HIFU can be a help for those subset of patients rather than undergoing an extreme treatment with surgery or radiation and causing all these morbidities, which may impact their life, their social life, their work life, and everything else. Now, in this area with the intermediate group and a subset of high-risk group, we are able to do focal therapy. And also we can use it in relapse for patients that have salvage treatments when the prostate cancer recurs after undergoing a definitive therapy such as radiation therapy. What patients are ideal for treatment? This even includes for surgery as well. You have to have a good life expectancy. If you're, let's say, 75 years old, your parents live to the age of 95, 90, you're in good health, not a major disease, you're able to do your chores, you're able to take care of yourself, and so you are a good candidate for the treatment. That doesn't say because you're 75 years old and forget about it, because some of those patients that have a higher life expectancy. I have a patient who are the subset of group of the centurions where his parents lived to the age of 107, 108 in Italy, and he is 75 years old. I expect him to live longer. So I offer him treatment. It's not a cold cut the way that they presented, for example, for President Biden, that because he was after the age of 70, we never checked the PSA again. That's why they're in that situation right now. But ideal candidates specifically for HIFU, good life expectancy. We would prefer the cancer to be on one side of the prostate in one area, not all around. Gleason 7 score, that's the sweet spot, specifically 4+3. We really like that for the treatment. We are able to see it with the MRI. The prostate is less than 50 grams. Calcifications less than 3 to 4 millimeters are acceptable. The reason for that is that calcifications can act as a barrier. When the ultrasound hits it, it comes back. It doesn't go beyond the calcification, which you cannot treat the tissue, but also can heat up higher than in the area that can be risk for your rectum. Also, if you have rectal injuries in the past, you have GI diseases such as ulcerative colitis, which may thicken your bowel, that's not a good person to do focal therapy, transrectal HIFU on. Now, how does this work? I tend to have the patients to do an enema in the morning of the treatment. I have the patients also have liquids the day before. This helps us to not to deal with feces which can interfere with the ultrasound. Also, on the day of the procedure, you come in, you go under general anesthesia, and then when the urologist, along with the staff, clinical help from the EDAP, from Focal One, they're present also in the room on majority of cases. We place the probe, we scan the prostate, we fuse it with the MRI, we identify the area that we want to treat, and then we create a goal, and then we treat the targeted tissue. After this, the patient, prior to this, also patient gets a catheter. Why is that? You are unlikely to pee after this procedure by yourself, because anytime you cause an inflammation, when you hit the tissue, you're causing a cell death. Your body attacks it, tries to eat it up, tries to destroy it, so you get the swelling. So that's why you get an indwelling catheter, and you are discharged on the same day with that indwelling catheter. I also like to start the patients on tamsulosin if they can tolerate it, on an alpha blocker 2 weeks prior to surgery, and I follow it minimum 2 weeks after the surgery if they're not on it. I also, for erectile function, penile rehab, I place the patient on Cialis at least a month before to help with the return of erectile function. After the procedure, I give patients 5 days of antibiotics, and on the day of the catheter removal, I give them single dose antibiotics in the office. I also, for some patients that may have discomfort with the catheter, which is a very rare subset of patients, I give them, if they have discomfort such as bladder spasms, I give them a medication such as Gemteso, which helps to relax the bladder for the duration that the catheter is in. After the treatment, you will be discharged home with what I have mentioned. You will have the catheter between 17 to 14 days and the medications that I mentioned to you. I see you, I remove the catheter. After a successful trial of void, you go home. Some of the things that you may experience afterwards, some patients may have some blood in the urine on and off. This will resolve and go away. I obtain a PSA at 3 months after the procedure. I expect the PSA to drop about 70 to 80%. That's when I know that I had a good treatment for that prostate cancer. And then I continue to check every 3 months for the first year. At 1 year, I always obtain an MRI of the prostate. And then decide, most likely, as a protocol, to obtain a prostate biopsy to assess for the recurrence. This is just the way that we have set it up at the focal meeting. Also, this will continue for at least 5 years. So we change the duration at year 3 to every 6 months, just like the way that you do radiation therapy. However, if your PSA starts rising after a certain amount of time that is substantial, the 3 rises will push us to obtain an MRI earlier and to obtain a biopsy to see if the cancer was treated, it has returned, or the therapy did not work, which is very rare. There are many clinical publications, thousands on this. In Europe, on certain patients at the meeting, they said, if you do not offer focal therapy to the patient when you see him for prostate cancer, that's as if you're doing malpractice. This is not okay. It should be offered to most patients because they're available. But like I said, it depends on surgeon to surgeon, location that you are, the availability of it, which may impact what kind of a treatment you get. This is a study that was done in Europe. It was published in December of 2024. If you look at this, they followed patients for over 30 months. They compared almost 2,000 HIFU patients and 1,400 radical prostatectomies across 46 centers. Majority of these patients that they had focal therapy were treated with Focal One HIFU. What they found that the cancer-free survival, the salvage treatment-free survival for HIFU was about 90%, while the radical prostatectomy was about 86%. And in the group of that received the focal therapy, urinary continence was maintained. As I told you before, radical prostatectomy, you could be incontinent for 1 month, for up to 3 months, sometimes 6 months, and beyond that, most likely you will require secondary treatment, which is a surgery either with slings or an artificial urinary sphincter, secondary treatment. in regards to erectile dysfunction, the group that received the focal therapy, less likely they developed erectile dysfunction, obviously comparable to the radical prostatectomy. This is another paper, landmark paper, that includes 418 patients, which has a good power of the study. And this study actually showed that the HIFU or focal therapy is very effective in this subset of patients. And it will help those patients that they have recurrence after radiation therapy to get them off possibly of androgen deprivation therapy, which I cannot say any male want to be on androgen deprivation therapy where their testosterone production is shut down and you're living in menopause. That can have adverse cardiac events. You are more fatigued. You have no libido, no erectile function. You get osteoporosis, among many other issues, so even depression. So androgen deprivation therapy is not a favorable therapy, but we have to utilize it in certain cases. And if you can get the patient off ADT with even performing HIFU, then that's favored. Also, this is another publication recently, as of April of 2025, that they had looked at a large cohort of patients who underwent therapy, focal therapy, after 2016. Those 25% of patients that they received with 84% chance treatment-free survival by 5 years. Meaning, if you recall, I told you that the patients that they have active surveillance, the reason we follow them is that the good portion of them may advance either higher stage or the PSA goes higher, which they're not low risk anymore. And those patients in this subset, 84% of the patients out of the 25% that got the focal therapy, their PSAs remain low and nothing changed at 10 years. So this is a sample of patient of mine, as I had mentioned to you. This is a young patient. His wife is younger. He was very worried about his erectile dysfunction when I diagnosed him with prostate cancer. On his MRI, the prostate was rather small. It was 30 grams. He was getting up at night. He had urinary symptoms, and the MRI picked out a PIRADS 4 lesion. There was no extra prostatic extension, meaning it was confined to the prostate. I did a biopsy. On the targeted biopsy, the PIRADS 4, I found it to be 4+3. That's unfavorable intermediate prostate cancer, or grade group 3. And on the same side, lateral mid, which near the tumor, he had a 3+4. The rest of the biopsies throughout the prostate, which was total of 26, were all negative. His PSA after 12 months went from 8 to 2.5 and is remaining there. The 6 months MRI was negative and he showed a very nice defect. After the catheter removal, he had dysuria, which resolved. And then his urinary symptoms, the IPSS score, which includes the obstructive symptoms, nocturia, all of those improved. And he's continent. He rates his erections 10 out of 10, and he's very happy with the procedure. So this fit the patient. But all of this, even that PSA remaining low, I will continue to follow this gentleman for 5 years because there's always a risk of recurrence of prostate cancer infield, meaning the area that I treated, but also on the contralateral aspect of the prostate, which we'll have to follow. In conclusion, HIFU or focal therapy, there are no scar, minimal to no blood loss, no incontinence. It's a non-invasive procedure. It can bridge the gap on some patients on active surveillance, and you can treat the hemigland, meaning one side of gland, to both sides, and also can help the patient not to go under major therapies such as definitive therapies such as prostatectomy, removal of the prostate, or radiation therapy. As I showed you, there are thousands of publications. These are promising data. This is being more promoted into the United States. A lot of institutions are adopting it. In Los Angeles, quite a bit of institutions, including Cedars-Sinai, Providence St. John's, UCLA, USC, they are all offering focal therapy. Thank you.
Doctor, that was an outstanding presentation. Let me open up my window here to see who might be open to some questions tonight. Why don't we start with Chuck Metzger? Dr.
Yeah,
Metzger, how are you this evening?
good, Neil. Thank you. That was just wonderful presentation, very concise. I think one of the things that we have to remember is your one slide showed that people on active surveillance have a certain percentage of incontinence and impotence and side effects, even without treatment. And so that isn't necessarily the only thing you look at when you decide treatment. But it's certainly the focal therapy is ready for prime time. And why it's not more used, I'm not sure. I think it's just institutional resistance, but it certainly offers a whole lot of promise. And I think fellows like yourself are just doing a great job with it. And we thank you very much for presenting this.
Thank you so much. I appreciate it. Thank you.
Ira's with us tonight. Ira, your observations?
Good evening. Thank you for a wonderful presentation. What is the success rate versus failure rate with HIFU?
As I had mentioned to you, the success rate, when I showed that slice, the risk of recurrence at 1 year, for example, one study in Australia showed that after HIFU in the same area that they treated, actually they did a double tap, which is meaning they treated the area twice, was as low as 7%. But overall, we quote that the lifetime possible recurrence of prostate cancer, depending on the grade of your disease, the aggressiveness of your cancer, and the volume of it, can be as high as 25 to 30%. But you have to pick your patients. That's why it is very important to choose the right patient when you're offering this. And if the patient does not meet the area with the subset of patients with the low comorbidity and low risk of recurrence, you have to be very clear and upfront with them that you probably going to have a recurrence within probably in a year to 2 years, that there is a recurrence rate because your prostate cancer is so aggressive. And some people, they choose to do that. But for a model patient, the recurrence rate is about 20 to 25%.
Doctor, earlier you mentioned that you do different types of focal treatment.
Yes.
So let me ask you, is there one that is better than the others, or is it
No.
based on your skill level?
Yeah, not necessarily. What we know about the Focal One, the transrectal HIFU, Focal One, which is the robotic base, we have the most data comparable to all other modalities of focal therapy. That's the most accepted one. We understand the technology, which is thermal. But as I mentioned to you earlier, there are a subset of patients that this is not the best treatment option for them, such as if the location of cancer is anteriorly right above the urethra. Not that you cannot treat it. You have to take the catheter out, you can treat it. But the problem with the treating of the cancer that is on top of the urethra and you're treating it from below, you have a higher probability of causing urethral stricture or other sequelae, which you don't want to deal with as a patient. I understand in Germany, they do that more often than us. So I would like to see what their outcome is. But when you do a thermal ablation and you include in the urethra in the field, you are more likely to get complex issues. That's why when the tumor is on top and the person wants to undergo, for example, the therapy for that, the focal therapy, then your options include for some patients is cryotherapy, for some patients could be nanoknife because of the location of where the cancer is. Or if the patient has a lot of calcification in their prostate, that can render them not a good candidate for focal therapy. But if the cancer is in a location where you can achieve it with doing, let's say, hypothetically nanoknife, which is with needles, then that's a different therapy. So that's the one that you choose for the patient. So not one therapy doesn't fit everybody. So that's why we have other modalities, other inventions, other people are thinking to come along with different types of treatments. Does that make sense? I don't know if I answered
Yes.
you.
I heard something about the Captain study.
Yeah, Tulsa.
So is there any update on that?
Tulsa Pro, what I don't have the final paper on it. I was part of it, but I had to drop it because it's not an easy study to do. number one. And also, I'm going to be very frank with it. I don't know what is going to happen because of the issue with Medicare and elsewhere and the costs that it has. However, the Captain study, what it showed is that because it's a whole gland treatment on the study that they did, the patient's BPH symptoms were also included in the study, which, as expected, the IPSS score or their voiding function significantly improves from, let's say, from moderate to low. The PSA, for example, for the subset of patients, I remember 90% of the gland volume drops about 90%. Their PSA remains as below 1 on, you have to carefully pick those patients, but these were not group 3, but they were group 1 and 2. They have higher risk for urinary incontinence. And also higher risk for erectile dysfunction.
Outstanding.
Yeah.
Ira, any other questions?
I'll let the next person ask some questions.
Thank you.
Thank
Adam,
you.
I know you have some questions. Adam Fleck? Adam, if you can unmute and we'll recognize your question.
Hello?
Hello?
Adam, is that you?
No, this is Lal.
All right, Lal, why don't you
I
go
have a-
ahead?
Okay, I have already typed in my question is what's the cost difference between radiation and HIFU? Also, is it covered by health insurance?
HIFU is covered by Medicare, is an FDA approved, is covered by Medicare. Other insurances, we always have to get a pre-authorization to ensure that they cover. So for the PPO insurance, we always get a pre-authorization. I've had luck with getting authorization for very hard insurances.
Also, what are the side effects from HIFU versus
So side effects associated with any focal therapy include an average 21% risk for erectile dysfunction, includes 2.46% of urethral stricture, 1.3% for urinary incontinence. Recurrence, I told you, depends on it, but as I code usually as high as 25% on average recurrence rates. These are some of the issues, the risks.
And what are the complications that can happen from HIFU? What are the complications can happen with doing HIFU?
That's what I mentioned. Those are the complications that I told you that can happen with HIFU. During the HIFU surgery, it's unlikely that you're going to get any, but because we control it. With the Focal One device, with the great ultrasound that you have, you control the heat of how much heat you're doing, what the tissue response is, so you avoid having any damage to the rectum. But there's no such a procedure that exists that has zero risk. If I tell you 99% of the time there's no damage to the rectum, there's no damage to your any other surrounding organs, but there's that 1% that experiences risk. However, comparable to an invasive procedure such as radical prostatectomy, where I go invade your body with a robot and I remove a tissue, you have a higher likelihood of having complications. Same as radiation therapy. Radiation therapy is weeks-long therapy. It can have negative impact on your urination. It can cause impotence. It can cause secondary cancers. So everything that you do has a risk. However, focal therapy, the reason that is so attractive is that the complication risk associated with it is lower. That's why a lot of folks, they choose the focal therapy if they are a candidate comparable to other therapies.
Okay, thank you.
Thank you, Doctor. If we could get you to turn off screen sharing, we'll open this up.
Sure.
And I'll try
Question.
Robert.
Oh, I was here. Okay.
Oh, hi, Adam's back. Okay, hi, Adam. Go ahead and
so
ask your
sorry.
question.
I'm sorry. Now I'm outside and around and about this. So thank you so much, Doctor, for all the information today. My question is: this particular procedure viable with recurrence?
That's exactly. So the recurrence, it is it's an accepted form of therapy with the recurrence, because once we identify the area of recurrence of your prostate cancer. Let's say you had radiation therapy, your PSA starts rising, you get a PSMA scan, and you get a biopsy and an MRI. You find the area of the cancer that is positive. What you could do is that you can utilize HIFU as long as there is no contraindication, and it's a doable procedure for that patient. I recently actually treated a similar patient with the radiation therapy recurrence. The patient is not on any androgen deprivation therapy. I treated him like 4 months ago. Most recent PSA is 0.1.
Okay, so and I may have been unclear. So I had a prostatectomy about 14 years ago.
Prostatectomy, okay.
Yeah, so now my PSA is, can't remember exactly what it is because I've reached that point where quality of life and deprivation therapy and the fact that the oncologist said that because of where it's located near the rectum, he couldn't give me 100% of what he would like to give me. And so there's no guarantee that's not outside of the pocket. I can't remember what it's called. So I'm at a point now where why would I want to go through no libido, not even knowing that you can do what it is you want to do, if that makes any sense. So I've just come to the point where I think quality of life for me at this point is more about that. So that's the question, is that.
So let me ask you a question. What was your PSA recurrence?
Yeah, I think it was, I'd have to go back and look at it all. In your mind, just bury it, which I shouldn't do. But I think it was a 3-4. Then I think now the PSA, I think it doubled within the 2 years, sort of on the far end of 2 years.
Yeah.
I think it's still under 2. But of course, his big thing is it should be 0. It should be 0. It should be 0.
Yeah. So despite the androgen deprivation therapy, it's still higher. It's 2.
No,
you're not on it.
I'm not. My choice is not to go with standard of care.
I'm going to be honest with you. If your PSA for this amount of time, for months and months, doesn't change, even though you have a recurrence, let's say at 2.0 right now, and 3 months from now, you get another PSA of 2.0, you may have cancer recurrence. However, it might be low risk. You can have a 3+3 and don't require any treatment. You have to talk to the urologist as well as the oncologist to get an understanding of it. Because anytime the PSA goes up, doesn't necessarily you have to get a treatment. There's some subset of patients that they looked at a 15-year data, like I was looking at the USC, where the patient's PSA was stable at, what was it, like 2.3, 2.4 for over 10 years. Nothing changed, and this patient didn't get any treatment, didn't metastasize anywhere. So, however, in regards to
mine is on the rise. Definitely, it's on the rise.
It's look, number one, I have to look at it. It's not that it's not doable, but still can take a look at it. However, it has a higher risk for developing scar tissue, urethral strictures, which can not be a great thing. However, got to see how close it is to the rectum, because I need at least 1 centimeter away from the rectum, so you're not causing heat damage. And if you get a rectal injury, it's the most terrible thing to deal with.
And that was my point, is do I want to have, if it's used my mind, I'm pooping problems for the rest of my life? I don't really. Like, again, quality of life. I like a libido.
Quality of life, yeah.
And the thing I asked the doctor how many years. He said, no one's going to tell you that. But Adam, I would say 5 or 6 years. If you left it untreated, knowing what we know at this moment right now.
Yeah.
So anyway, I so appreciate your time today and the presentation, and that's why I'm very happy to be a part of this group. So thank you, everybody.
May I ask you, did you get genetic testing?
No.
You should get genetic testing. If you're BRCA positive, you have other treatment options that you can have.
BRCA positive?
Yeah. You should get genetic testing.
Okay, thank you. That's something that's never been presented to me. So I really appreciate that so much.
No problem. Absolutely.
Thank you, doctor. Thank you, everyone.
Thank you.
Thank you, Adam, for your insightful questions. And Bob is here from New Jersey. How are you, Bob?
I'm good. It cooled down here finally.
Oh, thank goodness.
Yes. Doctor, question. Hypothetically, to follow up the last speaker,
Sure.
Can this HIFU be used post-prostatectomy in recurrence if the recurrence can be found in a spot that's treatable by HIFU?
Yeah, like why not? If this is an area that we can try, but like I said, there are complications that you got to know, which is urethral strictures. How close this area is to your ureters. You have to have a proper imaging with properly knowing exactly where it's located.
Okay.
Dr.
But as
Afshar,
an alternative, for example, if a PSMA PET comes up with a spot where they want to spot treat with radiation versus
Yeah.
HIFU, what's the pro and con on that if there's a spot to treat?
So if you had radical prostatectomy, then you have a recurrence. The mode of therapy, the guidelines recommends consideration for radiation therapy, which is also androgen deprivation therapy plus radiation therapy. But the question is that how long you continue the androgen deprivation therapy, of how the data, to be honest with you, points toward getting radiation therapy to the area of the recurrence. And I cannot refute the data, but hypothetically, this is doable. However, like I said, gotta look at your life expectancy, gotta look at your symptoms, gotta see what would you lose if you do the known therapy of radiation therapy that is out there, because we have great data on it. What are you trying to avoid? However, I'm not gonna say that is not doable, but I would say the radiation therapy has more data available comparable to HIFU.
Okay. All right. Thank you.
Thank you.
Outstanding. Let's go down the list. Ken, any questions you would like to ask? Ken Smith?
Yeah, Dr. Afshar, thank you very much for your presentation. I enjoyed following you. It looked to me like you were stating that if the cancer is unilateral, that it's treatable. What if it's bilateral?
So if it is bilateral, like I said, the most perfect patient for the treatment with the HIFU, with the Focal One, with the data that has been collected, is a patient that has prostate cancer on one side, a single lesion, especially on the MRI, with certain qualities. However, if you have cancer on both sides, depends on the cancer on the contralateral side. Let's say if you had a biopsy and on the other side you have a 3+3 prostate cancer, on one side is 4+3, I will treat the 4+3, but I'm not going to touch the 3+3, especially if you're trying to maintain your erection. However, depends on what we discuss. If you want to treat that side with the HIFU beforehand, I'll tell you. You can tell me is, look, I'm willing to have more side effects, including erectile dysfunction, but try to do both hemiglands. So that would be it. But however, if the cancer is located on the anterior aspect, meaning toward your head, and that side, then probably not the best way to use this modality as a treatment of the anterior lesion.
Thank you. You mentioned a few facilities that are doing this procedure.
Yeah.
You did mention Loma Linda. Are you familiar with their?
Absolutely. To be honest with you, I do not know about Loma Linda. I believe they should have it, but I cannot say it. Sorry.
Yeah, I did a check on Google search and it looks like they do offer it. I just wondered if you had an opinion.
They probably have it. Like I said, it's an accepted mode of therapy for patients. So almost every institution is obtaining one. Academic institutions such as Loma Linda, I just can't see if they wouldn't have one.
Okay. I think that's all the questions I had at this moment, but I thank you very much for your presentation.
Thank you so much, sir.
Thank you, Ken. Claude, do you have any questions for us tonight?
It was a great presentation and everything, and actually I really don't. I think you explained it pretty good. Right now I'm a 3+3. It's mainly on the right side, and it's been about a little over 3 years that I was diagnosed with this, and it hasn't really changed much. So I'm just keeping an eye on it right now, more importantly, and then we'll go from there if things do change.
Yes. I think for Gleason 3+3, active surveillance is a good option. But one thing you can do is that ask your physician who diagnosed you to, for example, send your specimen, the positive cancer tissue for this test, either called Decipher or Prolaris or GPS.
I did actually get Decipher,
okay?
yeah. Believe it or not, the doctor said he was actually going to get an AI test of some kind. And about a year ago,
I would not. Yeah, I
I'm
know
sorry.
the Arturo. I think that's the name of it. It's an AI test that they do on a histologic sample. But you did the Decipher?
They did the Decipher. And then they said they were going to do an AI test, and then they did the cipher again. Now, the first time it came out to 0.30,
Yeah.
very low, and then the second time using the same biopsy, maybe the different ones, but the same off the same biopsy, it came out even lower, 0.22.
Yeah.
So it's very
low probability for you to have a metastatic disease. So that means that in 10 years, you have a lower probability that this cancer will advance and cause. However, this is what I'm telling you. That test is not a test for you to look at and say, I'm free. You got to follow because there are always false negative, false positives associated with these tests.
okay.
But decide
Definitely.
validated test that is part of the guidelines.
Thank you. Thank you so much. Yeah, I am definitely going to be, I'm actually looking for another urologist right now. And, but everything is looking good right now. We'll go from there. And thank you so much.
Thank you.
Ira, let me go to Marshall. I'm gonna circle back to you. Marshall, any questions this evening? Marshall, I'll circle back to you. I have Hugo. Oh, there you are. Okay. Any questions this evening, Marshall?
I think my question was if the cancer is in more than one spot, then this may not be the proper procedure. So if we get 3 or 4 spots of 3.3 plus 4 or 4 plus 3, then maybe radiation would be better than.
Not necessarily. Like I said, it's best to number one for the person who's familiar with this procedure to take a look at your pathology, take a look at your operative note of how the biopsy was performed, and also look at your MRI. That could give him a better insight if this procedure is an option for you or not. But also, if it is, then they will have to work you up for the calcifications in the prostate and other things to ensure that you are fitting for it. But I wouldn't just say it like the way you did. I think it would be best for you if you're wondering about this to have somebody familiar with this to evaluate it, evaluate the information.
Okay. Okay. Thank you.
Thank you.
Jessica, welcome. Any questions tonight?
No questions from me. I was a part of the planning team with Mar, so I'm happy to be on, and I thank you for helping out along the way and Dr. Afshar for presenting. So thank you.
Thank you for joining us. Robert, and then I'll go to Ira. Robert, how are you doing tonight? There you are. Do you have any questions?
Which Robert are you referring to?
Noonan Bell?
Well, yeah, I have no questions, and I'd like to thank you all for a great presentation.
Thank you.
Thank you for joining us. Ira, it's your floor.
Okay, let me ask you. Sometimes the focal therapy is not successful. So does this affect the choice of treatment afterwards?
No, as I said, you don't burn any bridges. That's a great thing about this. Meaning, if there is a recurrence, you can choose to get focal therapy again. You can choose to get have the prostate removed, or you can get radiation therapy. So you're not confining to one treatment and you're stuck with it.
Great.
Thank you.
I'm gonna open up does anyone have any parting questions before we say goodnight? I'd like to thank Dr. Afshar for joining us once again, and we look forward to seeing you in the future. And I'd like to thank the Focal One team for joining us and helping us put this together. By the way, we have a program going now at Prostate Forum where we're actively soliciting your input. Whether you like something, whether you don't like something, there's 2 ways you can do it. If there's something you want to see, something you'd like to see less of, some concerns that you have, email us at prostateforumoc, That's one word, prostateforumoc@gmail.com, or you can write to us anonymously at Prostate Forum Viewpoints, 1519 East Chapman Avenue, Box 380, Fullerton, California, 92831. And you can even write to us anonymously. We love your donations and gladly accept checks, and that's what helps keep our organization going. By all means, check out our website where you can pay by PayPal, or send us a check to 1519 East Chapman Avenue, Box 380, Fullerton, California, USA, 92831. If there are no further questions, I'd like to say good night to everybody, and I look forward to seeing Dr. Afshar and his team again.
Thank you so much.
Thank you.
Thank you, guys. Have a wonderful
Great
night.
meeting. We look forward to seeing you all again. Take care, everybody.
Okay. Bye-bye.